So we'll try to get through whatever we can today, and Friday's the exam, and then we'll go back full throttle on. And I probably will focus mostly on respiratory in the lab. I would think on Monday next, whatever that is, the 20th. And you know what they say about today, everybody? My other class had no idea what I was talking about. What's today?
Day after Pi Day.
Day after Pi Day, science major. What?
Is it St. Patrick's Day?
No, that's Friday.
That's a whole month.
Yeah. 15th of March. It's the Ides of March.
Oh, yeah.
Beware the Ides. Unless your name's Caesar. Yeah. Don't go to the forum. Yeah. I'm telling this other class who were a couple of years behind you, just first year. Did you guys have to read Shakespeare plays every year? And
Yeah.
thank God. I thought I had no idea.
It kind of stunk though.
Hey!
I'm not a big Shakespeare. I didn't think Hamlet was that good. I
You didn't
also
think
thought Catcher in the Rye was a terrible book.
Catcher in the Rye. It was an interesting thing. It was a one-shot deal.
Yeah.
He writes a book that says that's Pulitzer Prize winning. They did a very bad movie, one of Sean Connery's later movies, basically on that same Finding Forrester was the name of that movie, and it was basically the same kind of became a reclusive. Catcher in the Rye was like the coming of age story
Yeah.
for people for teenage boys back.
He
You're in the
kept complaining
40s.
about the ducks though, so I
What?
thought he was kind of like the second he started complaining about ducks, like where did the ducks go? I lost interest because this dude's more about ducks and his well-being. So
Hey, we don't even eat duck in my house. My wife had a pet duck, so ducks are off the menu. So much for that little bit of introduction, everybody out there in virtual land, including Chelsea. And let us move on. Okay, so the whole idea for me, perfusion is such a critical idea. It's getting blood flow where it needs to be. And so if you have oxygen and nutrients, waste products, etc., any of these areas that you can see, and so it's very, very precisely controlled, okay? Extrinsic and intrinsically. Obviously, extrinsically, sympathetic nerves and chemical factors, hormones, play a pivotal role. Again, the only nervous system that if you lock her out, we're getting it. Oh, you come on in, join the party.
Like, you guys walked out?
Yeah, I didn't mean to do that. So the sympathetic nerves are the critical players, again, for any kind of smooth muscle in blood vessels. And then auto control is the idea, and I commented on it a little bit when I did it out of sequence, about how blood flow is adjusted to go where it needs the most. Okay? Locally modifying their diameters. So it's almost as though they're regulating their own blood flow. We saw it in the kidney a lot, and we'll reiterate the kidney again. There's so much we don't have to do. Okay? Theoretically, it's like any, hopefully a good working machine with a certain degree of maintenance, taking care of yourself, it basically should take care of itself for the most part. Anything you do that messes it up, it basically has problems, and trust me, it's throughout your lifetime. When you do something that does mess it up, it's just the way it is. So you have to make, thinking sort of, not theoretical is the wrong word, philosophically is the right word. I mean, whatever choices you are, impacted. Like my middle kid, fairly healthy, he liked to do those extreme sports and messed up his knee because of it, and other physical stuff, doing, BMX biking. There's a lot of injuries sustained by that, and they follow you around over time. They don't seem too much when you're 16 or 17. Well, now that he's going to be 39, he feels it a lot. When he has to do fit, because he does work that's more physically oriented. So intrinsic controls within the organ, localized messengers we call paracrines. Those are the interesting chemicals that are utilized for that. Autoregulation, outside nerves, particularly sympathetic, with blood vessels and hormones, because really the chapter is more about that in this And so and they just give you some of the page references there. This is a very interesting chart about redistribution during exercise. And very, very interesting. Only about 20% of the total blood in the body, but during exercise, that jumps by a factor of 3.5 times on average. Skeletal muscles, think fight or flight. The arterioles dilate, blood flow to the muscle. So the other areas, particularly digestive, renal, GI and GU, gastrointestinal, genitourinary, goes down to really, comparatively speaking, a trace level. Okay. But you're able to overall maintain the average pressure that's there. So it's kind of a neat chart when you look at it. So this is what I mean. The brain gets what the brain gets. The heart usually gets a relatively small amount of the roughly 6 liters, 250 milliliters a minute of that volume. So we triple it roughly, we're going to increase it. But when we triple it, look at skeletal muscles, factor of 10. Skin, because you have to dissipate heat. So there's a certain amount of circulation that goes there. Normally, the vast majority, nearly half your blood flow, kidneys and abdominal, notice it's, so theoretically, if you increase it by a factor of 3, it'd be 7,500, yet here, 2,500. So it really doesn't change dramatically whatsoever. Okay. So if you take a look at what they are, I mean, rather 1,200. So it decreases when you might expect it to increase by a factor of 3. It decreases by roughly a third. So that's the redistribution. That's so interesting. And so regulating blood flow, reactive hyperemia is very, very interesting. They talk about intrinsic factors. The best way to see that, okay, is if we temporarily, when we get into female reproductive, we talk about menstruation. Effectively, it's a phenomena. What occasions menstruation are, if you recall from anatomy, those small blood vessels, the spiral arteries constricting. When they constrict, they create a pressure head behind, so to speak. So the blood accumulates. When the constriction releases, there's an enormous amount of blood flow that separates the already loosened layer. That develops. You have the 2 layers there, the basalis and the functionalis, and the functionalis sheds. That's reactive hyperemia. So if you have a tourniquet on something, when you release it, you get a lot of blood flow. That's why in surgery, when we use tourniquets, we release them very, very slowly, not rapidly, to avoid blood rushing in, let's say, to an extremity and tearing everything up. You just spend a couple hours trying to put right. That kind of things. So the intrinsic mechanisms are part of it, metabolic and myogenic. So what happens is metabolically, we lose, when you're active, it loses oxygen. We have a lot of waste products, okay? Direct relaxation of arterioles and precapillary sphincters. Most of it's related to nitric oxide. So these are triggers for nitric oxide playing a pivotal role in autoregulation. Endothelins, okay, are vasoconstrictors. Okay, they usually balance. Okay, so endothelins close it down, nitric oxide widens it. Okay, and usually there's that wonderful dynamic balance. But if blood flow is inadequate, the nitric oxide wins. And obviously, inflammation will increase the degree of blood flow. So those are all important points. Those are just localized factors. Okay, smooth muscle responds to changes to maintain perfusion and to avoid damage. So they stretch passively. Smooth muscles, and this is the typical stretch receptor. When stretched much, they constrict, so you don't get an overabundance of flow. Reduce stretch, they dilate. That's classic auto control. Most of the things, if you think of a muscle, typically when you stress it, it constricts. Okay, if you relax it, to some extent it expands. That's typically long term. Okay, takes a while, and long term, a lot of times, if we're going to start. So if you decide, I want to get back in shape, I'm going to start to work out, you're going to have to build up enough blood supply over time. So maybe you've experienced it yourself. Take it for somebody like me who did 0 exercise for the first 55 and a half years of their life. None of you are looking at me astonished by this. which I find somewhat offensive. You're smiling behind the mask. I can see that. Sticking out her tongue at me behind the mask. I can just see it. Yes. And my wife explained to me, she goes, I do like 25 minutes on a treadmill. I'm like, oh my God, I'm gonna die. I must have had to speed up to 3.2. And then she said, like every time you go back there, you're gonna see you can do more and more. That's part of this long-term autoregulation, angiogenesis, they enlarging and creating more blood vessels. Okay. And we see it, altitude plays a role if you end up moving. And this is part of the sort of the behind the scenes theory when someone has, when you look at somebody, either they're immediately post a stent, where they do some type of coronary artery procedure, and then it's part of the rehab to avoid something more, potentially uh, more risky in that regard. I don't mean to do the light. What did I do? I didn't do it. I got it back. And they just summarize it all there. So varies with different types. Okay. About, as you can see, skeletal muscles about 1 liter a minute. Active or exercise hyperemia. Again, you can increase flow by a factor sometimes of 10 times. So imagine what's trained athletes and sports science has become so sophisticated that they're able to do that. That are there. It's quite remarkable what we were able to achieve today. Looking at what happened in sport years ago, how just knee injuries alone were career enders, and now people come back, and to some extent they come back relatively rapidly. And in many instances, Tommy John surgery was considered a career ender for a lot of people, and now it's being done relatively early in careers, particularly for baseball pitchers. There's a whole lot of that type of thing. Absolutely the best broken field runner I ever saw. Only played for 6 or 7 years. Anybody ever saw? Named Gale Sayers. Tore up his knee. It was never the same. That's 7 most amazing Hall of Fame years you ever saw. Okay, the brain, constant. It's intolerant of ischemia. Doesn't matter. It will adjust to maintain it. Blood flow is critical. Okay, so decreases in pH or increases in carbon dioxide lead to vasodilation, and unless it's extraordinarily high, then you can overwhelm the autoregulatory mechanisms. So there's a lot of controls that are there. So it's very much of extremes that are there. Why does someone faint? There's a lot of reasons. A lot of times people just get overheated. It's really very much of a transient drop. Sometimes it's almost, I hate to use the term hysterical, but let's call it neurogenic. And I've seen it with people just faint. It's like my daughter fainting at a needle. When we're doing the blood lab, I shared that story with you. Oh, don't worry, she's not going to faint. She's going to faint. Boom, she fainted. Okay, that type of thing. You're my daughter in another life. Let's face it. I'm blessed. So, and over 160, if it's very, very high, then the term that we use in a hospital sense is called malignant hypertension. When somebody comes in and they're 240 over 180 or 240 over 160, that's a stroke looking to happen now. And we would immediately run IV agents way back in the day. I'm sure they're changed now, that would rapidly take down the blood pressure. We have to wrap one of them in aluminum foil because it was so sensitive to any light, not just outside light, but it would start to deteriorate. I think that was why. No, I think Wyoming was to bring it up. Because I remember seeing that done in emergency when I first started there years ago. Skin, obviously, helps body temperature. That's why we begin to see that. And indeed, there's a fair amount of your blood supply, 5 or 10%. Thank you. Okay. So there's a lot of variation with regard to the skin, typically controlled by the sympathetic nervous system. Also, perspiration is involved with that, etc. Temperature rises for whatever reason. Okay. Vasomotor stimulation, dilation. So it's basically sympathetic in origin and it has a lot to do with dissipating heat is the way you would look at it. Temperature decreases, just the opposite. The skin constricts. And it's interesting how it constricts so rapidly that we'll see like rosy cheeks when someone's out on those really cold days because it constricts and temporarily traps the blood that's in there. So some of the phenomena are explained that way, which I think is fascinating, that are there. The lungs, okay, different area. It's because the vessels, because the names are different. The arteries are more like veins. The veins are more like artery. It's a low pressure system. Uh, everything works opposite, if you want to think of it that way. Low oxygen levels cause vasoconstriction, and high levels promote vasodilation. And that's one of those things I mentioned before. That that's the interesting dichotomy of the body, just like only having one kidney, having a limited amount of gastrointestinal tract. When we talk about that, you don't need a whole lot of that. You can do without the entirety of your colon and still survive. The interesting thing is a lot of things in your lung, we can move air around to where it can be brought in and expelled as needed, almost to the point where it would be somebody who would have to be on oxygen for the rest of their lives. They can have a chronic lung disease and not know it until they get to the point where there's nothing they can do about it. That's the beauty and the curse of our systems to overwhelm it. It's remarkable, I think. And you grow an appreciation when you see how it both helps people and, unfortunately, less appreciation when it hinders people. Okay, obviously the blood, we looked at the heart. Okay, and when the heart's pumping, the coronary vessels are compressed, but we have stored myoglobin with oxygen. Okay, and we're able to, and as you can see, the aortic pressure is really the spearhead. When the heart is, the residual aortic pressure allows the blood to flow in the coronary. So it's about 250 millimeters, myogenic mechanisms, strenuous exercise 3, maybe 4 times. Okay. There is, cardiac cells use a large amount of the oxygen as compared. Remember, most cells, we're looking at that 1 out of 4, the oxygen leaving one heme site, or one fourth of the hemoglobin, as opposed to the heart, where it's different, the way the myoglobin is and the way that is carried in that area. And then in the capillaries we looked at, and it's as you can see, it slows down. Speed, again, inversely related to cross section. So you can see what happens. You have a ton of capillaries, but the velocity is because that's where the exchange takes place. And this is one where they begin to show you some of those levels, I think. Okay, and everything with regard to these precapillary sphincters controlling flow. Diffusion obviously plays a role. These are the different routes. It's useful to remember, though you would know them. Okay, transmembrane, nonpolar, small, lipid-soluble molecules, gases, clefts, the tiny intracellular clefts in nearly all the capillaries, save the ones in the brain and in the testicular area, water-soluble products, fenestrations that you remember mostly in the kidney and other areas, and then a certain amount of active transport that can be involved. And they show you all those pictures again. And then this has a lot to do, and really, again, it's not a whole lot different. And we revisit this very much in kidney physiology, where we look at the relationship of the force, the blood pressure, which is the hydrostatic pressure, the force of water, and its opposition by the proteins in the system, which are the colloid osmotic pressure. So one's pushing it out, and the other one, a la Godfather 3, pulling it back in. Every time I'm out, they pull me back in. What fun are you? Did you ever watch The Sopranos? And he would always do that number. Hey, hey. But every time I'm out, they pull me back in. So the hydrostatic pressure In the capillaries, forces fluid through the walls, depending on the anatomy of the capillary, 35 at the arterial end, 17 at the venial end. The interstitial fluid hydropressure pushes it back in, but really it's about 0. The big player that pulls it back in is the colloid osmotic pressure. That's plasma proteins, about 26, 35 to 26, a net roughly around 9. The interstitial fluid osmotic pressure is fairly negligible. So when they do the math, okay, effectively what happens because of the 35 at the arterial end of the capillary, it goes through, it filtrates, it goes out. At the venular end, now you have about the same difference, again, somewhere between 8 and 10. It pulls it back in. It's really, and again, in this case, rather than concentration gradient, which certainly plays a role in what comes in and what goes out, but the flow of the fluids and the general movement of the fluids is pressure, is the driving force. And so, so you can see all of those, and that's what they're beginning to show you. The difference between hydrostatic and osmotic pressure. Here's the numbers. So at the arterial end, 35 to roughly 26, depending on this, because these are relatively minimal. And you have a net filtration pressure of 10 going out of the capillaries. And on the flip side, as it goes through the capillary bed, it begins to reverse as materials are absorbed. Okay. And so what happens, the proteins remain as the pressure dissipates and is pushed out, the fluids are pushed out. Now it goes back and the net filtration pressure is bringing materials back in, roughly 8. So they're close enough, significant. What happens when there's an excessive amount of fluid pressure or an excessive amount of fluid loss, for whatever the reason? Edema. And edema is extraordinarily important. It's a very telling sign. When someone has, it's one thing to have a swollen ankle because you went out in a sporting event, you twisted your ankle. Fine. It's going to swell up, elevated, ice, rapid, whatever you're going to do. Most likely it's going to get better relatively soon. When we look for it, when we see edema unilaterally, you typically look for a traumatic cause. If there is none, then the suspicion is something is blocking the return of the fluid. A mass, a tumor. Pregnancy is very common. Bilateral edema, when it's just roughly the same on both sides, first two things I think of, heart, kidneys. That's where the problem is. That was a question they asked me on a residency entrance exam interview. Yeah, I love that stuff. So for those of you going into medicine or one of those exams, I'll describe to you what it looks like. You're sitting at a big conference table. There's like a dozen doctors, and you're the incoming doctor trying to get the residency. You sit at the top of the table, and they fire questions at you. And I'm like, next one, give it to me. They applaud. No, look, go ahead. I'll strain and pat myself on the back. I didn't get that residency because politically it was a fait accompli. Fix was in. So all of those things. So an increase in capillary hydrostatic pressure accelerates fluid loss from the blood. Why would that happen? Okay. Increase in outward pressure, fluid not being pulled back in, could result from bad valves, varicose veins, localized blockages, mass, an embolism, a thrombus, heart failure, excessive blood volume, that's usually kidney related. Inflammatory responses, you would think of that being more traumatic in nature. A decrease in capillary osmotic pressure, not enough proteins, think liver. That's one of the things we see with liver disease, with hepatitis. And you would see somebody come in, they would be all swollen. Okay? From those type of things, post-hepatitis. It would really be very distorting. That was there. And certainly for malnutrition, the same thing. Malnutrition, liver disease, kidney disease. The distinction in the different kinds of edema is very straightforward. Pitting means it's fluid and relatively recent. Long-term edema, because eventually the proteins consolidate, becomes much firmer. So pitting edema, and I'm sure they'll show you a picture, is when it's and it's a standard thing you do in a hospital. You put your thumb over a bony prominence, let's say the ankle, and you press on it, and it leaves an impression. You grade it by how rapidly that impression fills back in from 0 to +4, +4 being the worst. I mean, I've had those where I've gone and come back and it's still there after seeing a couple more patients. And so edema, all of those things, now you have this fluid mass and you can't get exchange, nutrients, waste products, any degree of compensation that's there. If it remains untreated, then eventually it solidifies, it becomes a woody or a solid kind of edema. Now that can happen from other reasons like hereditary damage to lymph vessels called lymphedema, infection, something that we see in elephantiasis, which is a parasitic infection. So here's the idea. You put it over, let's say, the dorsum of the foot with a thumb, and I mean, that'll be there for a while. Okay? That's it for blood vessel physiology. Aren't you happy? Raise the roof. So I don't think I have anything more. I think we did all the allergy part of the program. We did. Very good. Which brings us to respiratory. We're going to spend our time. So for those of you who I will do an extraordinarily brief synopsis of respiratory anatomy and a very, very brief synopsis of the main tenet of respiratory physiology. Aren't you excited? More or less. Respiratory can be summed up, I said to the folks outside, two gentlemen outside, one of which is not here now. Here's how you summarize respiratory. In with the good air, out with the bad. Respiratory Physiology 101. In with the good air, out with the bad. So, this textbook does it differently. To me, they talk about respiration, and to me, cellular respiration is the oxygen carbon dioxide exchange at a cellular level, and pulmonary respiration, the same thing, but at a lung level. So I don't get too caught up in that. So to me, those are really the different kinds of respiration. They have some different names. And the beauty of this system with the last ones that we've done, with the exception of the immune system, is the interrelationship between the heart, between the blood, the heart, all the vascular units, blood unit, the heart unit, the blood vessel units, and respiratory. They're all aligned together. We alter our respiration to deal with what our heart's doing. If we're exercising and doing more rapid, we have to breathe more rapid. We have to marry the minute volume of our breathing to the cardiac output level. So if we're moving 6 liters of blood, we have to reoxygenate with 6 liters of oxygen, period. If you can't, if there's a fault, if you can't continue and balance those two out. That's the single most important start. And yeah, there's other stuff that's there with smell and speech. And I don't spend a whole lot of time on that, but a little bit just for the sake of completeness. Why it's such an important, the single most common problems that we have from an infectious disease standpoint are respiratory. Okay? The most common diagnosis that people have of a microbiological infection is a URI, an upper respiratory infection, nearly always viral. Okay? Our whole world changed almost exactly 3 years ago because of a lower respiratory infection, so named COVID. In this case, COVID-19. Okay? So that's how impactful these things can be. Everything altered because of it. To me, and frankly, I don't think it's going to change back anytime soon. I think we're always going to be, despite the politicalization of all of what's gone on, I mean, people are responding differently to these kinds of things. And oh my goodness, every time somebody sneezes, 3 people jump 6 feet away. Drives me crazy. Okay, sorry. Don't get preachy. They don't want to hear it. So, they call it ventilation. I call it respiration. They call it external respiration. I call it pulmonary respiration. To me, the two of those are the same thing. Okay, ventilation technically and we're going to look at that, the movement in and out. The one equation that you need to remember in this, you're going to love this, the ideal gas law. I love that. We chemistry majors, Dr. Hilbig is trying to get me to remember a chemistry thing. PV equals nRT. Circulatory, transportation, internal, which I call cellular respiration. That's fine. Here's the system. We've looked at it before. It's the interplay between the lungs, the heart, and the blood vessels, and the capillaries, and the delivery system. That's what it is. Review the anatomy if you didn't have me for the anatomy part of the program, or it was a while ago. Okay? Arbitrarily, most authors will tell you that the larynx is the dividing line. And most of them, this one tells you the larynx kind of starts the lower. So the anatomical divide, less of our concern today. Okay, that's the distinction between upper and lower respiratory infections, is typically the larynx. To me, if you get a cold and you end up with laryngitis, it's probably upper. If you start with laryngitis and end up with difficulty breathing, it's lower. So to me, that's sort of the transition zone. Most of the time, head and neck problems are upper respiratory, chest problems, lower respiratory. So they make the larynx the dividing line. They're all significant because it's a relatively short system, but it's a tremendously large volume system because of the anatomy of the lungs, which are all about surface area. All those wonderful alveoli that you'll remember, or that you'll look at as we kind of quickly scroll through these pictures, are intimately associated with blood vessels. Every bronchi or bronchiole has blood vessel, has an artery and a vein, or an arterial and a venial, or a capillary bed surrounding it, because it's constantly, they follow along with one another because of this intimate association that's there. So anatomically, when you pick up a lung, it's spongy. It's filled with air. The only solid stuff are the cartilaginous tubes that are in there. The rest of it is air and membrane and blood vessels elegantly designed for exchange. That's really what they look like. So, I mean, we can go through this and all that stuff. It's so not too long between your diaphragm and your nose. Not a whole lot of space. Yeah, you have a lot of modifications for extra volume. You have paranasal sinuses. The nasal cavity is large. The pharynx is the tube. It's like an open-ended hollow funnel, open-ended in the front, behind the nose and the mouth, and the larynx, aptly named naso, oro, and laryngopharynx. You have the epiglottis, the dividing line. And what is unique about this system, the rigidity, and because the rigidity ensures what's called patency. And patency means keeping it open. And that rigidity is not from bone, as much of our rigidity is from cartilage. And with the exception of the elastic cartilage of the epiglottis, it's all hyaline cartilage. The most common cartilage, and certainly the paramount cartilage, and anatomically, we're not going to do it again, but you should take a look and review them. All those, the laryngeal cartilages, the epiglottis, the thyroid cartilage with the prominence in the Adam's apple, the cricoid cartilage, the tracheal rings, the bronchial rings, etc., etc. The system further divides, this is our part, now we begin to look at it, into a functional division. Nearly all of that picture you're looking at, okay, is the conductive division. all about moving the air in and out. The exchange or respiratory division doesn't happen until it opens into those little sacs of alveoli. When they start to be visible, we've entered the exchange division. What it means is that the oxygen and carbon dioxide are so close to those blood vessels, effectively barely separated by membrane, that simple diffusion is enough to acquire the exchange. In the conductive division, it's all about getting the air to that point or getting the air out. Exhalable air with carbon dioxide. It's the whole ball game. In regard to that. I used to hate doing this unit and I smoked for all those years. So June 20th, which would have been my mom and dad's, are you ready? 80th wedding anniversary. Okay. They'd still been around. Don't think they'd have made it till 80. Okay. 15 years smoke free. I'm a building. I have a smoke free sign. That's my kid on the golf course when he and his buddy were smoking cigars. Dad, we got a cigar for you. Sorry, I'm not starting again. Okay, so functionality. We have the nose. Airway moistens, okay. Filters, moistens, and warms. Because the air has to be temperature-wise to ensure adequate exchange. Okay, those are all parts of it that are there. Filters, moistens, and warms. You have resonating, olfactory receptors. Not a whole lot. This is all anatomical with the nose. Not doing it, not doing it, not doing it again. The septum, the nose is almost all cartilage except for the bridge, which is the nasal bones you'll remember from anatomy. And everything else is there. The lining is interesting. We have the hairs, which are functional because they're filtration, that are there. The olfactory mucosa, which is for smell. The respiratory mucosa. So they differ. The olfactory epithelium are special sense that we looked at before. Respiratory, remember this, what's the one cell that we see everywhere? Pseudostratified, ciliated, columnar epithelia with goblet cells. That's a guaranteed question. You know, the cilia beating, little oarsman. Ramming speed. Ben-Hur, 1959. Loved him, hated her. Goblet cells, okay. Not a big deal. Defensins, we looked at some of this stuff. Serous cells, watery. The mucosal cells, more mucus, more proteinate. Lysozyme and defensins, sweeping the mucus, trapping the particle, warm biplexes. And typically what happens is they alternate. It's like, when you have a cold, one side kind of clogs up and then magically that unclogs and the other side clogs up. It's basically, it does that. That happens all the time. We just notice it more when we have a cold. That are there. These are anatomical, all the parts for bone, which really increase surface area, okay, etc. Sinuses, what they do, not a big deal. That are there. Inflammation, rhinitis. The pharynx, not a whole lot. Again, this is anatomical. Quick review. Lymphoid or lymphatic tissues, adenoids, which are in the pharynx, even though they're at pharyngeal tonsils. The auditory tubes, you remember all those anatomically, the eustachian tube. The interesting part, again, that they're more horizontal, and as we're by about age 4, they become more vertical. That's one of the reasons for ear infections that are there. Nothing. These are the zones. The respiratory zone is where diffusion takes over. What defines a respiratory bronchiole, and that's the start anatomically of that zone, is it opens up into alveoli. We actually start to see alveoli adherent to those very, very tiny respiratory bronchioles. They do not have any cartilage. They're merely smooth muscle tubes with open, and they're relatively flimsy. So they lose their rigidity or their patency per se. Okay. The conducting zone is everywhere from the nose until what are called the terminal bronchioles. Those are the last structures that have any fragments of cartilage. They have tiny plate-like areas of cartilage that are there. And this is all the cartilages, and we're not doing it, and the taste buds, and et cetera, et cetera. And I don't do talking because I don't like it. Hello. The trachea, once again, it's shorter than you think, 3/4 of an inch diameter. Remember, it opens up posteriorly, C-shaped, horizontal in nature, with the opening posteriorly for the trachealis muscle. The esophagus is behind it. Standard arrangement, which you're going to see here again, ciliated pseudostratified epithelium for the most part, other than those areas where you occasionally will find some simple squamous or some specialized tissue. The submucosa is usually, in this case, we're not dealing with muscle tissue yet. It's all cartilage with connective tissue. And again, the outer layer is called adventitia because it's not designed. It doesn't have a soft, moist lining. It has a comparatively dry lining that's there. The trachealis is the muscle, plays a role in expelling mucus. The last one is the carina, which is very sensitive, and it bifurcates into the bronchi. Remember, the one on the right more declinated, the one on the left more horizontal as it goes over the heart. That's why from an infectious standpoint, why most problems with pneumonia are right-sided. They're there. They show you the picture. Here's the cartilage. Here's the adventitia, which is really just connective tissue cells. And here's the pseudostratified ciliated columnar epithelium and the goblet cells. Nice looking cilia. Come back right away if you stop smoking or stop exposure to something that's noxious to it. I'll say it 58,000 times. The problem with that, if you know someone who's a long-term smoker, if you can get to them before roughly 20 pack years, that's a pack a day for 20 years. Somewhere in that, if somebody smokes a pack a day, and at your age, maybe they're only doing it now for a handful of years. If they stop, they can substantially lower their risk to lung cancer. I cannot. Mine will, anytime if they find a tumor or a nodule in my lung, the odds are it's cancerous, even now. Okay? Heimlich, we're not going to get into. We're almost done, everybody. Give me a minute. Okay, we're basically done. I will come back. I'll ask you to review these structures anatomically, and then we're going to get actually into probably starting about here with the actual physiology of respiration. We will do that on Monday and Monday in lab. We'll have our respiratory day in lab. Thank you.